Well, good morning, and thank you, all of you who were here yesterday and the speakers. It was such an energizing day, and I've heard so many positive comments, and I really want to thank everybody who helped. Could I just ask members of the Planning Committee who are here to stand up so that we can recognize you? Thank you. To have this kind of an interdisciplinary agenda really took an interdisciplinary planning committee that could help to connect us with people across the university and beyond, and I really appreciate all that they did to help us get there. So today we're going to focus, connect with Tom Frieden, former director of the CDC, who now runs a new organization called Resolve, and we're hoping that it all goes well. We've tested the connections. But we'll play it by ear if it doesn't, and we'll ask the panel, the two panel members and Jane Threlkill to get started a little earlier if that should fall through. But we're very optimistic. So we're going to look, after Tom Frieden, we're going to look at issues of African Americans and minorities, and I'm really excited about that presentation. And then there'll be a very practical session on best practices in prevention and preparedness. And then Ralph Barrick is going to give the wrap-up talk and tell us how bad it could be and how we can avoid it. I think it's going to be a really interesting and fast-paced session this morning. So I want to call on two of our co-sponsors to welcome everybody this morning, starting with Emlyn Koster, who's director of the North Carolina Museum of Natural Sciences. And some of you may have seen the book at the book table yesterday that talked about the role of really the modern role of museums and their role as community partners. And Emlyn wrote the foreword in the chapter, one of the chapters in that, co-wrote. It's been really interesting to see how a museum can partner with a university and the broader community, and I've been really excited about it. And then Mike Cohen will, who's the director of the Institute for Global Health and Infectious Diseases and many other titles, and probably the best way you know Mike is by 4 letters PrEP, right? So. And we're really glad to have Mike as a colleague, as one of our faculty members shared with the School of Medicine. So, and then Leah Devlin, who is a professor of the practice in our school and formerly head of the health department in North Carolina, will come up right after them. So thank you all for being here, and I'm really looking forward to the presentations. So Emlyn, I will call on you first. Thank you.
Good morning, ladies and gentlemen, and Robert, thank you, and to Leah and to Elizabeth and others who have been instrumental in the organization and realization of going viral. I say thank you, I'm sure, on your collective behalf. I have the pleasure of just saying a couple of things about the context of the interest and participation of the North Carolina Museum of Natural Sciences, which you see has a logo on the bottom of the screen, and also to introduce the next gentleman in the program. You may know the North Carolina Museum of Natural Sciences. It's been around since 1879, just 20 years after Darwin published On the Origin of Species, which is in itself incredible. Going strong and expanding, and with a mission that says that we are in the business of illuminating the natural world and inspiring its conservation by asking questions of what do we know, how do we know, what's happening now, and how can the public participate through citizen science. Museums are unique agencies in the service of society and the environment, and for too long they've only looked back in time. We are comfortable in this museum at sort of embracing that this is a critical moment in the continuity of time, past, present, and future. So I hope that if you haven't come to know us, you will do so. It's a major resource. It's the most visited museum in North Carolina, the most abundantly used field trip destination, and one of the top attractions of the region. I'd also say that when we came to know that UNC Chapel Hill and the Global School of Public Health was contemplating commemorating, if that's the right word, such a terrible disaster after the First World War. We somehow, I think through Leah Devlin, whom I had met, she invited us to come and have a close look, and it seemed to me that this event should have a public face as well, this convening. And so tomorrow at the museum in Raleigh, downtown, there is a sort of a continuation, a public version of what you're talking about here with several of the speakers. And we appreciate that that's become our opportunity, and we're delighted to be in the profile with this event alongside with our colleagues at RTI and UNC Chapel Hill. So thank you to all involved. It's my pleasure to introduce to you Myron Cohen, MD, maybe well known to many of you, with his education coming from the University of Illinois, from the Rush Medical Center, from the University of Michigan, and from Yale. Dr. Cohen is a distinguished professor in epidemiology with the Skilling School of Global Public Health and the School of Medicine. He is a director of this university's Institute of Global Health and Infectious Diseases, and he is an associate vice chancellor for this university for global health. He is a renowned specialist, a research specialist, career-long in the field of AIDS, and his work in this was recognized as the achievement of the year, the breakthrough of the year by Science magazine, which probably we all know to be one of the world's premier journals of science published by the American Association for the Advancement of Science. Particularly connected to my world, since I work with the state government and the Department of Natural and Cultural Resources, which administers the annual awards for excellence by the state. Dr. Cohen was recognized in 2011 with the Premier Award for Science in the state of North Carolina. So please welcome to the podium Myron Cohen, please. Thank you.
Well, one of the first rules of public speaking is never follow someone with a British accent. You never can sound erudite. It's impossible. You have such a huge advantage. So I think, let me thank you for those kind words, and let me just indicate, as was noted, I direct the Institute of Global Health and Infectious Disease for the university. It's an organization designed to amplify the strength of our health science schools and across the campus. I really have the privilege to welcome you, as Barbara did, on behalf of the University of North Carolina, to what I think is a great symposium. And let me thank the speakers who were terrific yesterday and will be terrific again today, and a really durable audience. I'm shocked to see this number of people on day two. There's almost, day two can be a really dramatic disappointment, and so thank you for your durability. My friend Barbara Reimer asked me to offer a few comments, which inevitably is going to be a few opinions, and she asked me to try and make them vaguely relevant to the symposium itself. But here's the problem. I'm an HIV specialist, okay? So we've really heard enough about influenza. It's really time for us to turn our attention a little bit to HIV. One can only talk about what they know about. So I have no choice. But in a more serious note, I think it's an opportunity to talk about as we will all day today, about the kind of bigger issue of microbial threats. That's what's really about is emerging pathogens and microbial threats. And I would argue that we've learned really critical lessons from influenza and from HIV and from other emerging pathogens. Probably the most critical lesson is that when we're faced with an emerging pathogen, as they were in 1918, but without the tools we have today, that it requires simplicity and focus. Those are the kind of critical things. And there are three things, for any threat, the three things we have to do we heard about yesterday. First, we have to know how to prevent the infection of risk at its inception. Second, we have to work on some way to manage the infection or treat the infection. We heard yesterday about respirators versus antiretrovirals, and that gets at management versus treatment. And lastly, for infections that are chronic, we have to figure out a way to cure these infections to avoid the morbidity, mortality, and continued spread of the agent. So 3 things: prevention, treatment, and cure. So let's, as I said, just talk for a moment about HIV, which I'm going to use an example of the challenges of an emerging pathogen. The highest priority for HIV and for any disease is to prevent the infectious agent, but that requires that we know the rules that govern the agent. The rules, the rules, the rules. For HIV, we spent decades, more than a decade, wandering around in a wilderness because we didn't understand the infection, and it led to the consequences of stigma and fear. And those are with us to this day in terms of trying to manage this pandemic. We had very ineffective prevention policies. But then, after maybe 15 years or so, we began to understand the rules that govern the transmission of HIV. We began to understand the disease itself much better, and that allowed us to have targeted prevention activities that are very successful, and ultimately life-saving treatment that has evolved to 1 pill a day and a normal lifespan for people with HIV infection. But this success was not fast. As I've said, it took more than 15 years to get to the point that I've just described. And as a cautionary note, we're still missing an HIV vaccine. So as we talk about universal flu vaccines as an aspiration, they may come about quickly, but it may be a long time in the making to realize that. Now, parenthetically, going back to influenza yesterday, we heard the remarkable story about the reconstruction of the 1918 influenza virus, and then we heard from the very scientists who conducted controversial and difficult experiments how they were able to understand the rules that governed the transmission of HIV, the 1918 strain of influenza, and the pathogenesis of the 1918 strain of influenza. I just want to dwell on that for a second. 100 years ago, that organism caused a crisis, and there's been tremendous fear that that crisis would be revisited. In order to deal with the crisis, the scientists who were with us yesterday, and Gina Kolata, emphasized work that led to understanding the rules that govern the agent. So it's always the rules, the rules, the rules when you deal with these infections. And Ralph Baric will talk later about some of these agents, and I'm sure he'll get into his work that leads to understanding the rules. So it must be obvious that it took 15 or 20 years for HIV, 100 years for influenza, but now we're in a very different era. The technological advances that have come about change the way we deal with emerging threats from years to understanding to literally weeks to understanding. So when we're confronted with Ebola or Lassa fever or new agents that we're not familiar with, the technology that's been developed really changes how we think about emerging pathogens. And I would emphasize, because we talked a lot about the kind of outbreak narratives, I don't see the technological advances at the expense of societal and behavioral issues. It is those technological advances that allow us to give this information to the public, which calms irrational fear. Once again, it's the rules that kind of set you free as we deal with emerging pathogens. Now, for HIV and any emerging pathogen, the greatest fear was, and will always be, airborne spread. So, and that is that drives every scary movie. So there's no scary movie that we talked about one. I have the trailers for Outbreak and all the scary movies. There's no scary movie that doesn't have you breathing air that makes you sick. And once airborne spread has been eliminated, there's a certain calm that spreads over the population. But HIV taught us another lesson. An infectious agent that is forever transmissible and chronic and hidden can sustain a massive, devastating epidemic. So while I think it's important to exclude airborne spread, one should not ignore the other consequences of some of these pathogens. So this morning we're going to hear from great speakers about how we should respond to microbial threats. They're going to focus on structural interventions at the level of society. I would only ask you remember that from my point of view and from our group's point of view, all the responses depend entirely on understanding the rules of the agents. It's the rules, the rules, the rules. And that has to drive, the science drives all of the kind of interventions and activities that transpire. So knowing the rules and our ability now to learn the rules more quickly using the technologies that were described yesterday offer us tremendous advantages over past generations and societal advantages as well. So this morning we'll move from the science that we heard yesterday more towards the interventions directed at emerging pathogens. I think the reconstruction of flu and the experiments that were described yesterday from our colleagues that were really kind of breathtaking science, that demonstrates the kind of future of our approach to microbial threats. So thank you for being here for the second day, and I hope you'll enjoy this morning. Thank you.
Thank you, Dr. Cohen, Dr. Koster, Dean Reimer. I'm Leah Devlin, and I'm delighted to be back here with all of you again today. I wanted to just drive home the point again about how this event has been developed by our partners, and that's the hallmark of how we work together in public health in North Carolina through partnerships and through collaboration. I'll be moderating today's very exciting session featuring Dr. Tom Frieden, who is joining us from Delhi, where it's already 6:15 p.m. in the evening. We remember when Dr. Frieden was here with us in person at our School of Public Health, and he spoke to hundreds of our students and faculty, and it was incredibly inspiring. In fact, we're still talking about it. So we're really delighted to have him back with us again today. We are privileged to hear his perspective as one of the world's top public health experts in the world on how strong policies can make us safer around the globe. Strong policies, not just in the United States, but in other countries, particularly focusing on middle income and low income, low resource countries around the world. We will have time for questions, so please be thinking of how you want to engage with Dr. Frieden and come to the mics quickly after his remarks. Many of you already know Dr. Frieden from his leadership worlds in the nation and around the globe. I first had the opportunity to get to know Dr. Frieden when he was the New York City Health Commissioner, and he and his amazing team worked on so many important public health issues and with such ardor and effectiveness that he actually led to a rapid increase in life expectancy in New York City. Now, those of you who know Dr. Frieden well, particularly from our infectious disease community, know that he has made his mark also in tuberculosis control and also prevention. He has led the investigation of the outbreak of the largest multi-drug resistance efforts in our country, and he also was foundational in establishing the largest tuberculosis control program in the world in India. So he's come full circle this morning. Probably his most visible role for all of us has been as the director of the Centers for Disease Control and Prevention from 2009 to 2017. Because of his work there, Americans, all of us, are safer from antibiotic resistance, foodborne and healthcare-associated infections, heart attacks, strokes, cancer, and exposure to dangerous pathogens, including Dr. Cohen, HIV, And for this morning's purpose, pandemic flu, but many others, Ebola also comes to mind. Dr. Frieden continues to be an ardent advocate for a strong Centers for Disease Control and Prevention. Dr. Frieden is currently the president and CEO of Resolve to Save Lives, a $225 million 5-year initiative housed at the globally focused nonprofit Vital Strategies. This effort is funded by Bloomberg Philanthropies, the Gates Foundation, and the Chan Zuckerberg Initiative. The goals of Resolve to Save Lives are twofold. First is to literally save 100 million lives over 5 years by implementing proven solutions to prevent heart disease and stroke, which are the world's leading causes of death. The second aim of Resolve is to prevent the next disease outbreak by catalyzing urgent country action around the world to detect early, respond rapidly and efficiently to an emerging outbreak, either a tried and true pathogen or a new emerging one. If anyone can save 100 million lives, if anyone can build capacity in countries around the world to strengthen their public health system, it is Dr. Tom Frieden. We look forward to his remarks and to the discussion he will have with you. Dr. Frieden, the remote microphone from India is now yours.
Thank you very much, and it's great to be there with you. First, let me ask if you can hear me all right. Yes. Great, and I can hear you. And when I do this, can you see my slides? Fantastic. Despite a big storm outside and many thousands of miles, I feel like I'm there with you and really do appreciate the chance to share. What I thought I would do is speak pretty quickly about some of the key issues and then open it up for a discussion. And of course, as we are in 2018, we think back 100 years, and I've seen your program. It's very impressive. It reminds me of a retreat I went to with some congressmen years ago, where at the end of the retreat, someone said, everything I wanted to say has already been said, but not by me, so I'm going to say it. And I'm afraid I may be repeating some things that you've already heard by people who are certainly more knowledgeable than I about them, but I'll give you a sense of my take on where we are just with influenza, but with a variety of health threats. So let me move to the slides now. Let me just verify that the slides are up with you. Yes. Great. And I'll focus on the word policies for a moment. Policy is the royal road to progress. Program tends to get the attention and the funding, but often policies are what drive more rapid health progress. As you all know, the global pandemic from 100 years ago killed probably more than 50 million people worldwide. And look at that graph on the bottom right, this dramatic decline in US life expectancy. So massive global economic disruption, and it killed more people in 24 weeks than HIV killed in 24 years, and more in a year than the Black Death killed in a century. Most of those killed were previously healthy, and around the world, health systems were overwhelmed. Have we learned lessons? Well, in 1918, there were no flu vaccines to prevent infection. There were no antiviral drugs. I think you just saw my invitation to play squash on the screen. Sorry about that. My invitation to, there were no antiviral drugs to treat flu. There were no antibiotics to treat secondary infections. There were no mechanical ventilators or intensive care units. And there were no modern respiratory protection devices to reduce transmission. Now, we have made advances in each one of these 5 areas, but still in each one of them and in others, there are real problems. There is an increased globalization and interconnectedness, so diseases spread a lot faster now than they did a century ago. There are more novel pathogens, on average 1 a year. New vaccines can take months to develop, distribute, and administer, and have limited efficacy. And let me say that I I'm delighted that NIH has significant dollars for a universal flu vaccine. It's much needed. However, that is a long way away, and we could probably do a lot of good if we rigorously studied the 4 vaccine types on the market, figured out which worked best, and then used that information to optimize vaccine development. Pandemics will overwhelm even the best healthcare systems, and I recall looking at Singapore dealing with SARS and thinking, wow, if the very administratively efficient, let's say, city-state of Singapore has a problem with this, imagine what would happen if it hits elsewhere. And of course, the greatest moment of terror in the Ebola epidemic was when it almost got out of control in Lagos. And it was really just days away from getting control. Most of the world remains unprepared. And if you look at these areas, flu vaccines are still not going to be here on time in most of the scenarios of a pandemic. Antiviral drugs are here, but they have limited impact, and it's hard to get people to use them. Antibiotics to treat secondary infections are very important, but flu can kill from viral infection as well. And the mechanical ventilator challenge is not a small one. When I was at New York City as a health department, and again at CDC, I was quite concerned that ventilators were the lowest common denominator of emergency preparedness. And so the Strategic National Stockpile, in my time at CDC, greatly increased the number of ventilators, and we've looked at what could we do to increase preparedness, because it's not just the machine, but the respiratory therapists, and how can you scale that up in an emergency. A lot more now about transmission of flu. New studies show, for example, that source control, covering the mouth of the person who's sick, makes a really big difference. And the tradition in Asia of wearing a mask when you're sick has a lot to recommend it. As Leah mentioned, I'm currently honored to lead a global initiative called Resolve to Save Lives. Our goals are to prevent 100 million deaths from cardiovascular disease and to make the world safer from epidemics. We're delighted to have the donors that Leah mentioned, Bloomberg Philanthropies, the Chan Zuckerberg Initiative, and the Bill and Melinda Gates Foundation. We have core organizations that we support around the world, financially and technically, to establish a partnership on each of these 2 areas. And I won't talk much about the cardiovascular initiative since we're focusing on flu, although of course, as you know, influenza increases heart attacks in an important way. But we have a simple formula that 50/30 plus 0 equals 100. And the way that works is that if we increase global control of blood pressure from 14 to 50%, reduce intake of sodium by 30%, and eliminate artificial trans fat, we will get to 100 million lives saved in about 30 years. And the elimination of artificial trans fat would be the first global elimination of a non-communicable disease. The World Health Organization has now called for it, and I look forward to seeing real progress on that. In the making the world safer from epidemic space, we're focusing on core systems, the core 4 of tracking systems or surveillance systems, trained epidemiologists or disease detectives, strong laboratory networks, and rapid response teams that can stop outbreaks quickly. A disease outbreak anywhere is a health threat anywhere. Disease can travel across the world in just 4 to 6 hours. And there are lots of reasons why epidemics are missed and how they're found. For example, we know that it always, or just about always, begins with an alert clinician. But the alert clinician needs to have access to a good laboratory network, needs to have an ongoing relationship with the local health department. There needs to be a tracking system that can tell if something unusual is happening. There need to be trained epidemiologists who can analyze that, looking at the labs from the reported patients. And there needs to be political courage to say, even when it's not definite, there may be an outbreak here and we're going to take appropriate action. And this always comes up. There's always a voice that says, oh, but maybe it's not real. Oh, but we're going to have economic losses. Oh, but tourism will be down. So all of these things are necessary for epidemics to be found or reasons why they may be missed. The World Health Organization has international health regulations. These were updated after the SARS epidemic. And fundamentally, they talk about preventing avoidable outbreaks, detecting threats early, and responding rapidly and effectively. I'm extremely excited about the Joint External Evaluation process. This is the first time ever there's been a global accountability framework for epidemic preparedness. And it tells you very simply whether countries are ready. And what we know is that we're doing a pretty good job at assessment. By the end of this year, more than 100 countries will have gone through joint external evaluation. And yet, very few have gotten the money to close the gaps that are found. And these gaps are life-threatening gaps. So we've been trying to see if we can leverage resources to fix gaps in those critical areas of trained epidemiologists, laboratory networks, rapid response capacity, surveillance systems. This is some of the results of the joint external evaluation process. You can see that in Africa, there's not a single country yet that is documented as being ready. Some have work to do, some are not ready, and the ones that are blank here have not even asked for an assessment yet. Resolve will help to assess and track preparedness to address critical gaps. Most countries have the intention and determination to prepare for epidemics, but they're not adequately prepared yet. And so we'll focus on these 4 areas. We've already begun work, particularly in Nigeria, where there's a really good new public health institute and director. They're responding effectively to a very large outbreak now of Lassa fever, as well as multiple other outbreaks. But what we see there is what we see in many places. The better programs get, the more outbreaks they find. The more outbreaks they find, the more busy they are dealing with outbreaks. The more busy they are dealing with outbreaks, the less able they are to implement the systems that will prevent those outbreaks in the first place, whether it's vaccination or identification of risk factors or mitigation of risks from food and water. What we hope is that strengthening all of these systems will not only strengthen the response to unusual emergencies, but perhaps more importantly, strengthen the response. I'll come back to that in a moment. Epidemic prevention is smart spending. The cost of a pandemic is many times higher than the cost of preventing that pandemic. We estimate that it's about $1 per person per year in low and middle income countries to establish the basic core requirements for disease protection. But that money isn't forthcoming. I'm pleased that the current administration, the current Congress, I should say, funded the Global Health Security Program at CDC, even though that program hadn't yet run out of money. So it's very encouraging that Congress put $50 million more in CDC's budget this year. They've been running about $150 to $200 million a year program. It will expire next year. So if Congress, since the Congress put $50 million in this year, if they put $100 million in the next year and $150 million the year after, they'll make this program a stable program. As you know, diseases know no borders. And because of that, we won't be safe until other countries are safer. We won't be secure at home until countries are safer abroad. And that essential connection of the world is not going to change. And because of that, it is not only the right thing to do, but in our self-interest to help other countries become better prepared. In Resolve to Save Lives, we have 3 key principles: simplicity, speed, and scale. We're delighted to have great support from our donors, and we're delighted to partner with groups around the US and around the world to promote preparedness in any way we can. I'll just end with one thought. The systems that work most effectively are systems that not only can be scaled up in emergencies, but systems that work well every day. Systems that can identify a problem, respond to it promptly, analyze the situation, and scale up an effective response. Systems like that need to be used every day. They can't be fire alarms that you break the glass when there's an emergency. There's systems like the Vaccines for Children program that could be scaled up. There's systems like disease reporting that can be used effectively. There's systems like electronic death registration, which in a catastrophic event would be enormously important to tracking trends. What we have to do, both in the US and globally, is not only build programs and develop new tools, but better apply current tools to be used every day to improve response. And in that regard, I think this is a crucial lesson in the 1918 pandemic that is as relevant today as it was 100 years ago. Thank you very much.
Thank you, Dr. Frieden. You never fail to inspire and stimulate our thinking on what we all can do to help with this amazing global mission that you have undertaken. Thank you so much. Since you're not here, I just want to note that we have an audience that includes researchers from all over the country. We have practitioners, we have faculty training the future public health workforce, and a few people from the corporate sector here today. So I don't think there's going to be a lot of shyness in this group. So we're queuing for questions, and if you'll say your name, and I know you, Zach, Dr. Moore, but if you'll say your name and where you're from, and you succinctly ask a question.
Sure. This is Zach Moore. I'm the state epidemiologist here in North Carolina, and it's to your last point that my question relates, and that's I think many people get frustrated at this cycle of emerging threat, political attention, funding. The threat is addressed theoretically successfully, and then the funding goes away and it's forgotten, and it doesn't lead to any lasting increase in capacity for the next threat in many cases. And so I just wonder how, if you have any other thoughts on how we shift that narrative and towards building the fundamental capacity and sort of recognizing that what enables us to deal with this threat is in many ways the same as what would enable us to deal with future threats.
It's a great question. I don't have a perfect answer, but part of the answer is going to have to be outside of the government, to encourage the government to do the right thing. When I was appointed Assistant Commissioner of Health in New York City and Director of the Tuberculosis Control Program, I got some advice from James Q. Wilson, the leading scholars of government. And what he said was, you won't succeed and your programs won't be sustained unless you have groups outside of the government pushing for you to do the things that need to be done. And that's a very important lesson. I also learned a lot from Senator Inouye, who was then chairman of the Appropriations Committee in the Senate, who, when I asked this question, said to me, don't tell us the good things that will happen if we give you the money. Tell us the bad things that will happen to us if we don't give you the money. So I think a combination of those approaches is important. We also have to get better at communication, making clear that public health is about protecting everyone. There's a misconception in many quarters about what public health is about. A lot of things that public health does, people don't realize public health is doing. We have to try to make that more visible. Easier said than done, but every opportunity we have to do that, whether it's a flu season or an outbreak or a data release, is an opportunity to build momentum, to build support. When I was at the City Health Department and at CDC, we released a monthly report, did a telebriefing, got a lot of coverage on a variety of health issues. This is a cacophony of voices these days, so to be effective with it is not easy, but it's very important. Back over to you.
Yes, thank you. And those of us in the practice community join you in saying that we feel like the public health system is a quiet miracle. So we'll go to our next questioner.
Yes, hi. Hi, my name is Priscilla Wald. I teach English at Duke. Thank you for that amazing talk and for the amazing work you're doing. I'm really inspired. Also, that's the best Skype talk I've ever heard. That's not an easy medium. And what I want to ask you about, and I think I hear it in what you're saying, is how your organization thinks about and defines health. Because I'm thinking here of the work of Paul Farmer and also of Margaret Cho's call to return to Alma Ata and think of health as a state of well-being, a human right, and in that context, the need to address global poverty broadly as the single vector, most important vector that turns an outbreak into a pandemic. So is that something that your organization thinks about? I realize you can't do everything, and you're doing amazing things.
What results in the health status of a population really is very broad societal factors. From what's called the social determinants of health, poverty, education, housing. This is the substrate for health. Years back, I was principal for a day in a New York City school. It's a nice thing that was done. And I was with a group of 8th grade in the inner city. And I asked, what's the single most important thing you can do to live a long and healthy life? And I was looking for something like, don't get HIV, or don't smoke, don't do drugs. And one 8th grade young woman raised her hand and gave me a better answer than I had in my mind, which was graduate from college. And she was absolutely right. This is the strongest predictor of health, this level of education. Not the only, but the strongest. So that bottom level is the social determinants of health. Above that are things that change the default value. Clean water, clean air. Things that make it so if you go about your business, you'll remain healthy. You don't have to deal with cigarette smoke in your workplace, or as we do here in Delhi, salmonella in the water or food. The next level up are light touch clinical interventions, things like immunization, colonoscopy, or one-time counseling for tobacco use or alcohol use. These are interventions that make a big difference, and they can be done once or every few years. At a level above that are the clinical interventions that require long-term, consistent functioning of the healthcare system, like control of blood pressure, where globally we're only at 14%. And at the top of that kind of pyramid of impact is counseling, education, and one-on-one activities. These are 5 areas where we can affect health. And to maximally improve health, we want to work on all 5 of those areas. But realistically, our unique perspective in public health is, one, the ability to bear witness, to talk about where there are horrific inequities in health. Martin Luther King Jr. said, of all injustice, injustice in healthcare, inequality in healthcare is the most shocking. And if you step back and think about it, it really is. Someone lives or dies depends in many cases on whether they can get competent care. At the height of the Ebola epidemic, one of our very beloved drivers in Sierra Leone was waiting for our team in a parking lot. He began having seizures and bleeding, and he died. And the assumption was he must have had Ebola, so he couldn't be safely resuscitated in that context there. But when the situation was investigated, it turned out he had hypertension, which was untreated, and he had a stroke because of untreated hypertension. Globally, there are 1.4 billion people with high blood pressure, and 1.2 billion don't have it under control. And from that 1.2 billion people arise 10 million people a year who die from hypertension, more than all infectious diseases combined. Within the public health space, we can bear witness to inequalities and the need for improvement in the social determinants of health. But we can also implement specific programs that will make a difference and address some of those inequalities. Those specific programs include things like hypertension control, things to prevent epidemics, areas where we can make a big difference through reducing tobacco use or vaccinating against killer diseases. Our approach then is to work in the general in bearing witness, advocating, and trying to take where we can actions that will change the structure of inequality, whether that's clean water or access to family planning, which will reduce poverty in the next generation, or our specific programs like vaccination and hypertension treatment, which will make a huge difference in people's lives. I'll end with a story. When I ran the tuberculosis program in New York City, we had a terrible social situation. We had mass homelessness. We had people living in shelters. We had very poor infection control in hospitals. And multi-drug resistant tuberculosis spreading around the city. And there was one theme of thought that said, you know, this is not going to get better until we fix the housing crisis in Yale, our ability to do infection control in hospitals generally, and a variety of other things. And there was a sub-theme of thought that said, and even if we could control it, we probably shouldn't, because with tuberculosis, we can fix these other things. I didn't agree with that perspective. I wanted, of course, homelessness to be solved. But here we are 25 years later, and we've still got a big homelessness problem. But we don't have any big tuberculosis problem. And that's not just an individual issue. One of the big challenges at that time was that there was a small number of patients, 1-2%, who just wouldn't take their medications, no matter how sensitively they were offered. And they were very visible to the clinicians because they came back to hospitals, one of them 32 times infectious. And the hospital said, what can the health department do if it can't even deal with these individuals? So we established a secure unit to care for people with tuberculosis in the hospital until they were cured. And Boston had been doing this for years. So we went up to Boston to see their program and learn from it. And I kind of said, you know, these people have so many problems in addition to tuberculosis. Are you doing any good? And I'll never forget what the nurse said to me. She said, they come here, they've got tuberculosis, many of them are HIV positive, they're homeless, they're mentally ill, and they're drug addicted. They leave here, they're still drug addicted, mentally ill, we may or may not have found them housing, they may or may not be on treatment for their HIV, but they don't have tuberculosis, and that's not a small thing. It's a big thing for them in their lives. We've done them a lot of good. And I think more broadly, that's an important perspective in public health. Thanks.
Thank you.
Thank you, Dr. Frieden. We have talked about disparities in dealing with epidemics and reaching those who are outside the system or not participating in all of the efforts to contain an outbreak. So thank you for bringing that home again. Dr. Koster?
Thank you, Leah. India's Association of Science Centers is renowned for its attention to public health issues, much more than the rest of the world, in my knowledge. And this going viral symposium, as you may know, is accompanied by both an exhibition that opens next month at the National Museum of Natural History in the Smithsonian, and also a roving pop-up exhibit. And we're bringing it to a public front tomorrow at the North Carolina Museum of Natural Sciences. I would invite you, since you have such global knowledge, to recommend, if I may, to the more sort of Euro-North American museum and science center field. You know, what we should be doing more of in the public health area. It's not a subject that comes up very often, and it obviously is lacking in that regard. You know, we like to say in this country that more people visit museums than go to professional sports live each year, but we're not doing a very good job, I will criticize, in terms of being relevant to the issues that are this fundamental. So if you had the bully pulpit, if you were a keynote at the American Association of Museums meeting, what would you say?
First, it's a great exhibit. By all means, get whatever part of it you can. Second, the Centers for Disease Control and Prevention has a museum. It's affiliated with the Smithsonian. They have great exhibits. They can be rotating. They probably need some help with funding because Congress doesn't want to fund museums. But they're wonderful exhibits, very important, very powerful, very interesting. I would say even surprisingly interesting. I shouldn't probably tell the story, but I was walking past the museum one day, ushering Mayor Bloomberg into CDC, and we walked through the museum, past the museum, and I said, this is this. Not quite rolled his eyes, but kind of shrugged. And I said, you know, it's actually much more interesting than you'd think. And he said, it would have to be.
Thank you, Dr. Frieden. Dr. Koster.
It is actually quite interesting. There are some photographic exhibits that are very powerful and tell stories. And ultimately, what we want to do, whether it's about health or global issues generally, is tell stories. And there was an exhibit there, I'm not even sure if it's a CDC exhibit or a broader one, of where children sleep around the world. Photographic as well as demonstrations, and it's very, very powerful. And if you speak to the folks there, they're important. Plus, you can look inwardly at your local community. At the Museum of Natural History, we've done quite a few very powerful programs on health, both lecture series as well as exhibits. And there in North Carolina, you have a really good public health program. You can think about what you can do together. You can also, museums have been terrific at doing outreach to schools. There's important things you can do there as well. So those are a few ideas.
Thank you, Dr. Frieden. And we do work closely with our Museum of Natural Sciences here in North Carolina. We're going to take one more question. We're going to let Dean Reimer, the Dean of our School of Public Health, wrap us up.
Dr. Frieden, thank you so much, and thank you for your global leadership. I was proud to be able to hear you a few weeks ago when you spoke to the Association of Schools and Programs of Public Health, and you did a great job, and you did a great job this morning. I'm really struck, and I agree with your comments about speed, simplicity, and scale. And I wondered if you would just comment, there are a number of students here and faculty and others, what are the kinds of skills that maybe we aren't teaching so well in schools of public health right now that would help to achieve speed, simplicity, and scale?
Thank you, and thank you, Dean, for all the great work you do. It's great to hear your voice again and interact with you. I would start with simplicity. There's that old saying, I didn't have time to write you a short letter, so I wrote you a long letter.
Yeah.
One of the things that we're doing in hypertension treatment is simplifying. Not dumbing down, but simplifying. If you look at Kaiser Permanente, the top healthcare system in the US, their results are better than any other place in the US, and they use a very simple protocol. Start with half a pill, double it to 1 pill, double it to 2 pills. There's no way to get speed and scale without simplicity. So you have to start with that. And that means that the students that we train should be able to integrate information. As I said at that conference, I've often thought, if I were designing the final exam for a public health program, it would be, you've got 4 hours on the internet, here's the problem, give me a one-pager about what to do about it. And I thought of that because it actually happened. I was in New York City, and suddenly, as commissioner, I forget why, but there was an opportunity to establish a program in our schools to expand dental sealants. But we had 4 hours to develop a one-pager that would go to the budget office and the mayor and would be decided on. And a very good special assistant who knew absolutely nothing about dental sealants at time 0, by the end of hour 4, had produced a terrific one-pager that resulted in a big dental sealant program in New York City. And that kind of clarity and simplicity can lead to scale. On the speed issue, I think it's important to be relentless, especially in the public sector and the academic sector, to recognize that every day, every week, every month that goes by, and we're not implementing programs, people are dying. Bill Foege says that public health is best when we see and we help others see the faces and the lives behind the numbers. And for that, I think all of you in the audience are so important, locally, nationally, and globally, to help us see the numbers of people who are becoming ill, disabled, dying, or at risk for dying because we're not acting today to reduce the risks. So thank you all very much for what you do, and best wishes for the rest of the conference.
Thank you so much.
Thank you, Dr. Frieden, for your marvelous presentation and for putting us at the end of your day, which I'm sure is not actually the end of your day. You're going to keep working, so thank you so much. We're grateful for all of your leadership globally. Bye. Thank you. And now it is my pleasure to welcome to the podium this morning Dr. Jane Thrakill, who is a Distinguished Associate Professor of English and Comparative Literature here on our campus at UNC. And she also directs an initiative called Health and Humanities. So thank you, Dr. Thrakill.
Hello, everybody. I am Jane Thrailkill, so I'm here from UNC's College of Arts and Sciences. I am a professor of English, and I do run, along with Jordan Jack, the Health Humanities Lab here at UNC Chapel Hill. I'll be moderating this session on issues for minority populations from early 20th century to the present. When presentations conclude at 10:10, we will begin a moderated discussion and take questions from the audience. Because our agenda is so full, my comments about our speakers' biographies will be brief, but more information is available about speakers on the online program. World War I intersected with the 1918 influenza pandemic in important ways. For example, the fact that soldiers were packed into military units never built for the number of men who they housed, and were sent to Europe in boats that were terribly overcrowded. This created breeding grounds for the virus to spread quickly among the population of young men. These young men, unfortunately, proved especially susceptible to this particular strain of influenza. Ever since Dr. Reimer and a group of others created or imagined this influenza pandemic conference, or this conference about going viral, I've been noticing at the edges of television shows, novels, and other popular narratives in our culture mention the flu pandemic. But it's interesting, it's very rare that we have full novelistic representation of the pandemic. It's almost as if the gargantuan scale of it was somehow unimaginable for our expressive artists. So to me, as an English professor and a student of history, that to me is fascinating. So today, to speak about some of these related or questions that fall out from this important pandemic, we have Dr. Adrienne Lentz-Smith, who will discuss this period in U.S. history, and in the South particularly, in which Jim Crow laws dominated. Dr. Lentz-Smith is Associate Professor of History at Duke University, and she wrote about this in her book, Freedom Struggles, African Americans and World War I. Her book examines how African Americans worked through ideas of manhood, citizenship, and diaspora to pursue their freedom dreams. Her latest work is focused on Black lives and state violence in the twilight of the civil rights years. Second, we will have Dr. Sandra Krause-Quinn, who will discuss concerns about trust in vaccines and the healthcare system among minority populations. Dr. Quinn is professor and chair of the Department of Family Science at the University of Maryland's School of Public Health and director of Maryland's Center for Health Equity. She studies vaccination narratives and behaviors using social media, and she studies cultural beliefs related to vaccine and racial disparities, as well as vaccine acceptance in routine and emergency situations, racial disparities in vaccine uptake. Again, more information about these amazing speakers is available on the online program. We'll have time for questions following these two speakers at 10:10 a.m. Now please join me in welcoming Dr. Adrienne Lentz-Smith.
Good morning, everybody. If I were cornier, I would point out that we might call Dr. Quinn Medicine Woman. I'm sure it's not the first time that anyone's done it. And yes, I am that corny. I'm going to take us back to 1918, to the World War I years for a little bit. I imagine you were there with my historian colleagues a bit yesterday. But I want us to think, I don't know much about health, actually. My own is middling. But I want us to think about the world, the lives that people were living with, the world that the flu sort of impeded on, and what that looked like. And I want for us to keep in mind a little bit that, what do I want to do? That interventions, medicine and intervention only worked in so much as some people were considered worthy or deserving of care, and that others, and that people trusted that the caregivers or the people trying to make interventions had their well-being in mind, right? So that would limit in the 19-teens how folks could address the flu pandemic, and I suspect that were we to have other pandemics in our current moment, it would affect it now. So I'm going to open with a spectacle, a parade. On July 28th, 1917, nearly 10,000 African Americans paraded up New York's Fifth Avenue. Children first, then women, then men. All in their Sunday best. Women and children wore all white, as if they were attending a baptism. Men wore dark suits, as if they were on their way to a funeral. They kept disciplined silence, but they carried placards that proclaimed, in so many words, that Black lives matter. This protest came in response to the pogrom in East St. Louis. We call it a race riot, but race riots in this period were mobs going into Black neighborhoods, razing homes and business and murdering people, often by the dozens or the scores. It came in response to a pogrom in East St. Louis earlier that summer, to spectacle lynchings in Memphis and in Waco in the spring and the summer before. Spectacle lynchings meaning that they were done publicly, advertised beforehand in front of crowds of hundreds, and that people took body parts as souvenirs away from them in the aftermath. One placard challenged their fellow Americans, newly entered into a global conflict that President Wilson had labeled a war for democracy, to make America safe for democracy as well. Other placards made explicit links between Black people's military service and the rights of citizenship so violently denied them. And they form an account, if we sort of read them one after the other, of Black military service up through US entry into the First World War. Those placards read, "We have fought for the liberty of white Americans in six wars. Our reward is East St. Louis." Another read, "The first blood for American independence was shed by a Negro, Crispus Attucks." Another read, "Negroes fought for American independence under George Washington. We fought with Perry at Lake Erie. 12,000 of us fought with Jackson at New Orleans. 10,000 of us fought in the Spanish-American War. We helped plant the American flag in every dominion. From Bunker to Carrizal, we have done our bit." Another placard reiterated the tension and conundrum inherent in all these moments of African Americans' military service. Patriotism and loyalty presuppose protection and liberty. Yet, as the NAACP staffers who organized the parade and the 10,000 African Americans who marched well knew, government protection and the privileges of freedom, life, liberty, the pursuit of happiness, remained elusive goals. I want to jump ahead to the winter of 1918-1919 to read a few snippets from Black periodicals and the NAACP records. It's important to keep in mind that the Black press in this period was vibrant and a necessary alternative to what some might call the fake news being circulated about African Americans in white newspapers. Snippet 1. "The recent influenza epic has been no respecter of persons, and many people in the prime of their life were stricken down." An advertisement in the back of Crisis, the NAACP's monthly magazine, observed in December 1918. According to the ad, the standard-based life insurance company had issued payments ranging from $500 to $2,500 for flu-related deaths. Another snippet. In Pittsburgh, the men's division of the industrial branch of the local urban league helped to found an emergency hospital in a factory to address the flu pandemic. The hospital employed 14 African American nurses by 1919. Once the emergency passed, factory owners opted to hire on 2 African American nurses on a permanent basis. Stepping back to November 1918, let me cite a bulletin in which numerous NAAC branches announced their activities hampered, as the DC folks wrote, by the outbreak of the Spanish flu. In Charleston, West Virginia, for example, the branch set aside their Liberty Loan drive to focus on caring for the sick. Members in Beaumont, Texas wrote that they had been, quote, deprived of holding any meeting for 3 weeks on account of the Spanish influenza. The Montgomery branch, too, blamed the flu and the accompanying quarantine for keeping their numbers down. Investigating a series of lynchings that same November, the deputy head of the NAACP, Walter White, found a witness laid up in bed, sick with the Spanish influenza. Both White and the man's doctors tried to convince the witness to go on record with what he knew about these lynchings, a spate of them, horrific, including a lynching of a black woman who was pregnant and the subsequent attack on her baby, to testify on what he knew. White promised to relocate him and his 5 children up north for their protection, to find him a job, and to support him until after he testified. The man turned the NAACP down, citing his children's vulnerability, the fact that his aunts, cousins, and other extended kin would be left behind and subject to retribution if he fled, and that he owned 3 pieces of property in the surrounding counties. He would sell them, if he could sell them, at a great loss. Exile, then, would mean losing his livelihood and putting his family in the crosshairs of local white folks who had lynched at least 10 people since that May. Lying abed, tended by 2 doctors, that man understood better than Walter White that he literally could not afford to be brave. So what do these snippets tell us? On the broadest scale, they tell us that the flu interrupted lives being lived in all of their mundanity, ambition, tragedy, and horror. As the life insurance ad reminded readers, the flu was no respecter of persons. But these snippets give us glimpses, too, of the lives folks were leading as the war, then illness, raged around them. In the report from the Urban League, we hear a suggestion of the great migration of African Americans to urban centers, particularly in the industrial North. Dating from 1910 or so, the migration of African Americans out of the Black Belt accelerated with wartime mobilization, so that between 1916, and we can kind of look through to 1930, through the 20s, about 1 million African Americans left the South at a rate of about 500 per day. These numbers would accelerate even more. You know, the Second World War had even a sort of higher amount of migration. The report from various NAACP branches shows an organization with momentum, temporarily stymied though that momentum was. Founded in 1909, after a riot in Springfield, Illinois, the NAACP had grown steadily, but it truly bloomed during the World War I years, from 9,000 members in 1917 to 90,000 in 1919. With 300 local branches, the organization was very much what its members, often working class, quite often activist women, made of it. And then there's the Lowndes and Brooks County lynchings in Georgia. They were particularly horrific, but they were not isolated. By the most conservative estimates, 208 African Americans were lynched in Woodrow Wilson's first term from 1913 to 1917, and another 172 in the World War I years from 1917 to 1919. In some, folks just disappeared. Others were public spectacles. The Georgia lynchings had both. Such violence reminds us that Jim Crow, what Southerners proudly referred to as white supremacy, was a system of political economy structured and defended through white racial terror. More than a slogan and less than a fact, historian Steve Kantrowitz has observed, white supremacy was a social argument and a political program. It consisted of ideas and practices, promises and threats, oratory and murder. In other words, it was a campaign waged by white elites to limit African Americans' political, economic, and social power. And important, too, it was waged to keep everyday white folks in line. That is, to convince them that their racial interests, their identity as white people, trumped any other way that they might imagine their interests, their communities, and even themselves. Class, for example, economic interests, or a sort of broadly conceived religious community. It's important to remember that white supremacy was not static. It kept forming and reforming in response to political and social circumstances, especially in response to challenges waged by African Americans in the South and their allies. So World War I was one of these moments of disruption and remaking. Pro-war progressive, in the history sense progressive, you know, the sort of busy social reformists, they're sort of the public health forebears, right? Pro-war progressive John Dewey thought of World War I as a plastic juncture in which the world might be made anew. Most African Americans were a bit less florid in their optimism than Dewey, but they too hoped that the war might at least clip Jim Crow's wings. So in my remaining few minutes, I want to sketch for you what this moment looked like. The war would bring African Americans a host of new experiences. About 386,000 African Americans served in the wartime military, and millions more registered for the draft. 200,000 of them traveled overseas with the American Expeditionary Forces, 40,000 of them as combat troops, most of them as labor troops, largely because the Army did not believe in either the capacity for African Americans to fight or the wisdom of arming black men and telling them that fighting for democracy was a noble cause. Some people believed both at the same time. But mobilization became an occasion for all sorts of African Americans to think about their relationship to the nation, to the world, to their fellow Americans, to other communities of color. It also gave them a rallying cry, this idea of a war for democracy, for asking for or demanding freedom at home. It did not offer a distinct break from the dynamics of white supremacy. Rather, service abroad and service in domestic camps offered an extension of Jim Crow mores into their military space. African Americans fighting abroad found themselves wrangling with their fellow Americans, white Americans, more steadily and more often than they fought any foreign enemy. Soldiers wrote home about fellow soldiers arrested or shot for talking to French women. They wrote of riots overseas, race riots overseas. They wrote of lynchings in French towns. They sent back accounts of black officers. There were only a handful. There were fewer by the end of the war than there had been at the beginning, because they were often demoted for no reason other than that white officials didn't believe them capable of being officers. But they wrote also of the way in which France as a space offered them a place to be and experience being something other than debased, right? So not that France was without racism, it had its own empire and sort of colonial subjects to manage, but what France did, or what the French did, was to treat African Americans as Americans first, and black second. Basically, African Americans were not French people's problem, so they didn't try to manage them, right? Which gave black soldiers and folks moving around a space and a place to explore other ways of being. Intellectual and activist W.E.B. Du Bois captured some of the rage and resolve of African Americans veterans in his rousing editorial Returning Soldiers that ran in the Crisis in May of 1919. The editorial is angry, but purposefully so. In it, Du Bois decries the vindictive fate that had African Americans fighting for a dominant minority that had wanted to debase black folks as, he writes, servants, whores, dogs, and monkeys. he supplies a searing litany of ill-doing. It lynches, it disfranchises, it steals from us, it insults us. But in the end, Du Bois shifts to a call to arms. By the end of, he writes, "By the God of heaven, we are cowards and jackasses, if now that the war is over, we do not marshal every ounce of our brain and brawn to fight a sterner, longer, more unbending battle against the forces of hell in our own land. We return from fighting, we return fighting. Make way for democracy. We saved it in France, and by the great Jehovah, we shall save it in the United States or know the reason why." Du Bois's editorial had fury, but it also had great pride, and it had hope. When I first started writing my book, Freedom Struggles, I focused on that hope. But one reads books differently in different moments. And from my current vantage point, as I wonder about the care we take, or don't, with our current crop of returning veterans, many of whom hail from marginalized and even reviled communities, and as I watch with bemusement as people reject the current assertion that Black lives matter, in part because they seem to miss that that assertion is a rejoinder to the claim made in both word and deed that those lives don't matter, I better understand the hurt and the ferocity that underlies the Returning Soldiers editorial. Now, as I read accounts of someone like former Lieutenant Rayford Logan's writing in his memoirs about his Jim Crow shell shock, where he writes that he fought 2 wars at once, Woodrow Wilson's and his own, and he doesn't know which one did more damage to him. Or Black stevedore Ely Green's account of watching military policemen nearly kill Black soldiers in the stockade, mostly because they were bored and had nothing better to do. Or Green's other memories of being run out of Texas after the war by the Klan because he refused to stop wearing either his military uniform or his chauffeur's uniform. I grasp the rage that underlie Du Bois's editorial, rage which seared Black soldiers, either tempering them or consuming them, mobilizing them or eating them alive. But rage can't flame indefinitely. It burns through, turning to despair, indifference, or resolve. Black veterans knew this, as did the segregationists who opposed them. Each told stories, segregationist white veterans who wrote to their senators, warning them to guard against Black militancy, African-American soldiers who wrote to the government and said, y'all better watch out for we is coming. That is one, it's in the military intelligence files, because when you write things like that, you end up getting surveilled. But all of these things you see feeding a post-war energy, right, on both sides, growing African-American militancy, the viciousness of the Red Summer, which was a reaction in large part to the achievement of the World War I years. And all of them, I think, have something to say to us now. I'm struck by the number of soldiers who show up both appealing to the federal government in the run-up to World War II and warning them that this time around they're not going to serve loyally first and hope for reward later, that they are saying we will bargain with you now, get concrete rights, and then we will show up to fight. People like Charles Hamilton Houston, who was a judge advocate general during World War I, came out saying he would never be that powerless to defend people again, went to Harvard Law School, and becomes the lawyer who trains a coterie of lawyers at Howard Law School, including Thurgood Marshall. He's the midwife of the sort of strategy to bring down segregation through litigation. And Houston is interesting to me because he, like Rayford Logan and others, are people who felt as veterans that they were entitled both to their rage and to their rights. And because he pursued civil rights through the state, right, understanding state power, but through a state whose good faith he did not trust, and whose goodwill he never actually hoped for. It's an unrelenting pragmatism that is fascinating to me, even inspiring, and one that I think provides a way through thinking about how to advocate for and pursue positive interventions and change, even when so many things from the federal government as directed towards communities of color feel like betrayal. So, thank you.
Thank you so much. Now we have Dr. Quinn with her talk.
Good morning. Thank you so much for having me, Dean Reimer. This is very exciting to be here. Dr. Lynn Smith was provided a foundation for what I'm about to say in talking about more contemporary times. There we go. I'm going to talk about building trust in the flu vaccine, some of the challenges and opportunities with African Americans. Much of my work is focused on African Americans. However, some of the issues that arise also arise with other populations, and I'll speak to that briefly. So Dr. Lynn Smith she really described life in a Jim Crow South with extreme segregation. So let me quickly read this. Camp Wheeler, Macon, Georgia, October 26, 1918. Thinking soldier guards pacing the station platform wearing flu masks were a reception committee of the Ku Klux Klan. 1,300 Negro selected men were given the fright of their lives when they arrived here. Ku Kluxes, yelled the first Negro as he landed on the station platform and stared into the gauze masked face of a sentry. 1,500 Negroes then made a scramble for cover. It took the military authorities some time to convince the Negroes that the masks were intended to protect their lives. We can understand why a sense that those soldiers waiting were there to protect their lives was probably not within the realm of the experiences of the men getting off that train. Context matters, and context matters today as well as it did in 1918. So I have to acknowledge my research team at the University of Maryland, University of Georgia, and University of Pittsburgh. And what I'm going to do today is not talk about odds ratios and show you graphs and figures, but to talk about some of the themes we've learned in our journey in trying to understand why there are consistent year after year disparities in African Americans receiving the flu vaccine, even when the rate of disparities in chronic diseases that place many at increased risk of complications makes this a serious matter. So I'm going to speak from the data of 3 data sets, one conducted at the beginning of the H1N1 pandemic, one conducted sort of partway through it, as it turns out closer to the end, in 2010, and then one conducted in 2015. The first two, 2009, 2010, were whites, African Americans, and English and Spanish-speaking Latinos. The third one in 2015 was only whites and African Americans, because we really wanted to focus on those issues evenly split, a little over 100 of each. We did also extensive qualitative research with 110 whites and African Americans in Maryland and in Georgia. That included exploratory interviews, 9 focus groups, and then extended in-depth interviews. So I'm going to talk about sort of what we did and what we heard. So 2009, and Carrie Lubell told us yesterday, high levels of uncertainty, high media interest. There was certainly seasonal flu vaccine production was underway by the time we knew we had a pandemic. It was uncertain when or if we would have an H1N1 vaccine. And in the press, there was a discussion of having an emergency use authorization, which means the FDA in a public health emergency can approve the use of a vaccine or a drug that's really still in the experimental stages. So this was the context in which we decided to investigate trust and other attitudes. We measured in both surveys trust in information sources, local and state and federal public health agencies, local, state, and federal elected officials, President Obama, and the Secretaries of Health and Human Services and Homeland Security, who were both visible at the time of the pandemic. We looked at trust in other sources, news, different types of news organizations, healthcare providers, families, friends, and then trust in government action during the pandemic. Not trust in government writ large, but specific to how the government would react in the pandemic. How open was the government, how honest, how caring, how committed. To what extent did people believe that the government would act in their best interest? At the second survey in 2010, we also sought to understand how they felt about the communication. And so we were interested in how clear they saw the information being, how consistent, to what extent they were okay as information changed, as government learned more, and how open did they feel the government had been. Finally, President Obama talked openly about getting his daughters vaccinated. And so we were interested, did this change confidence and trust in the vaccine? So what did we find? Typically, when you do social surveys, you find African Americans, Latinos often have lower trust in government, in part because of all the things we just heard. What we found in June of 2009, several months after the inauguration of President Obama, that actually whites had the lowest levels of trust in government actions, and African Americans and Latinos had higher trust. Context matters. Public health officials, this will be good news for many of you who are practitioners in the room, for Dr. Devlin, who's devoted her life to this, that public health officials were more trusted than elected officials. So bad news for the elected officials. Personal health care providers were highly trusted by by all three groups in these surveys, but African Americans still trusted them less than whites. And finally, people who reported they closely followed the news, they were paying attention and had high level of knowledge actually had higher levels of trust. So again, see that theme around communication, understanding, and information. But we also heard that trust alone did not predict vaccine uptake for African Americans and Latinos. When we did, and that was in the first survey, when we did the second survey, we did find some promising things. That the quality of communication made a difference, that the extent to which people were following the news, the extent to which they saw the quality of communication as being high, and the President Obama's willingness to talk about his daughters actually made a difference in trust in government action and trust in government spokespersons. And that's important. So we'll come back to all these in a moment. The other thing is that quality of communication made a difference. We asked people who hadn't yet gotten vaccinated, did they intend? And that quality of communication was a variable that made a difference, moving them from no to either I don't know or yes. But given what we heard here, we knew we didn't fully understand this. Trust is actually often the bucket. When we can't explain all the variants, we say, oh, it must be trust. Well, what we recognized is a couple of things. Number one, that we needed to understand trust in the vaccine, not just trust in government actions. And we also, we learned in listening to people during our qualitative research that whites, no matter what their age, and African Americans had sort of two foundational kinds of perspectives. For whites, they said, you know, the polio vaccine was such a success. You know, it just made me trust. I don't question vaccines. African Americans, the first focus group, not surprising, I was not shocked at this. First person says, how can you even talk about vaccines without talking about the Tuskegee syphilis study? So, you know, we heard those things sort of from both. African Americans were more likely to talk about conspiracies around the flu vaccine, everyone united in talking about pharmaceutical companies having a profit motive. When whites question the competence, or when whites question government around vaccines, they question competence. When African Americans question, they question motives. Would government act in our best interest? And finally, they also had different perspectives on perceived risk of the vaccine itself. So whites tend to think of if their side effects are going to be mild, my arm might be sore. African Americans saw them as far more serious. You could die. It's a live virus. It can kill you. So we used all that to create a number of valid, reliable measures. We measured generalized trust. We asked about trust in the flu vaccine, and we had heard that nobody understood this process we go through every year of creating a flu vaccine. So we created an infographic and literally showed it to them, and then asked about trust in all the parties present there. And what we found, let me back up before I go to findings. The other thing is we were influenced by public health critical race praxis and really hearing white privilege and the perspective of African Americans in the qualitative research. So again, we created a set of variables. Racial fairness is trust, is treatment in healthcare or by the government fair to one's race? How conscious are you of your race in a healthcare setting? Have you experienced discrimination? And what impact does that have on your ability to get healthcare? And we asked this of both. We asked from the perspective of one's race, because we thought we were hearing white privilege, and we were certainly hearing what it feels like to live as an African American in the United States. African Americans had lower trust in all organizations, but the same rank order as whites. So doctors, one's personal doctor, CDC, so good news for the CDC folks. FDA were trusted. Pharmaceutical companies were where everyone agreed. They did not trust the drug companies. But we also found, and this is the good news, that when you measure trust in the vaccine itself and in the production process, that it actually did predict increased vaccine uptake. So we'll come back to all this a little bit later. But there are a couple of other things that are tied to this, that higher perceived disease risk, lower perceived risk of side effects, higher knowledge of the flu, older age, and higher income are associated with trust. So those are important things to think about. Higher racial consciousness, so the more you're conscious of your race in a healthcare setting, and experience with discrimination, not surprisingly, was associated with higher perceived risk from vaccine side effects, lower trust, and lower uptake. And so this was really powerful for African Americans, not significant for whites. For both groups, interestingly, higher perceived racial fairness was associated with higher trust in the process, the vaccine, and greater uptake. That was for both groups. So what do we do about this? How do we address and increase trust and uptake of the vaccine? So in the focus groups, while we certainly heard a lot about Tuskegee, we also had a number of people who said things like this, and this is two different African American participants. The mistrust needs to be done away with. Some of that stuff is just old and outdated. So the same thing with this vaccine indoctrination mindset. Some of that stuff is just old. The government has become more trustworthy in some areas, and so I was willing to give the flu vaccine a shot. By the way, this is 2013, maybe early 2014. I trust them, and I'm going to tell you why. There are too many people that work in government that have our best interest. So please, don't think the government is trying to hurt us if they say, go get your flu shot. I don't believe they are. So that's what I mean. I think we have some opportunities and some ways forward, not without challenges. But what do? So public health agencies, be they local, federal, I think do a good job at talking about get the vaccine. They do a good job at talking about risk of the disease by and large. However, there's still a lot of misinformation, misunderstanding of the vaccine, of flu itself. And certainly we saw that as associated with trust. So I think some of the communication needs to begin to address that issue. The perceived risk of side effects. We don't often talk about those things. And I think the clear message about quality of communication is we need to be open and talk directly about these. If we don't, social media will, and others will. So that's an important communication message. Finally, we did hear a lot about barriers, and higher perceived barriers were associated with lower trust. And so those barriers were perceived as costs, for sure, but they were also things like, well, is that vaccine that I get in my black neighborhood the same as the vaccine that you get in your rich white neighborhood? Why do we have shortages, but you don't have shortages? So attention to those perceived barriers, and I say perceived, because the perception is as important as if it were the reality. But a couple of other things we learned, that when we looked at vaccine behavior across 5 years as we did, clearly what we saw is that we need more attention to younger African Americans, lower income African Americans. We did a paper that literally just looked at our African American participants by their vaccine behavior. And so I think we have opportunities because we have a universal flu vaccine recommendation. We have opportunities to reach out to younger people, to lower income people. But the quality of communication is essential here. And in a pandemic, we often say, the key principles: communicate early, communicate often, be open, address uncertainty, warn your population, your public, that there will be uncertainty, information will change. Dr. Frieden actually did that very well. Demonstrate empathy. Say that you understand this will be hard. And CDC has learned that lesson actually pretty well since anthrax. The caution in today's media period is not to get engaged in myths and misinformation. That's a longer conversation. We also found that language matters. And so when EUA fact sheets talk about things like experimental drugs, clinical trials, that is immediately a trigger, particularly for African Americans, and that decreases likelihood. So language matters. We cannot do this unless healthcare systems change. This is not just on the backs of the population and African American communities, but addressing what we know is still problematic. Racial bias in healthcare is critical, and I'm heartened by some of the efforts to do implicit association tests and other efforts to increase the ability of providers to address and trustworthy, build trusting relationships. But we also know that providers in general and African American providers do not take the flu vaccine. That's a critical issue. If I'm asking you, do you take it, and you say to me, I don't take it, that is going to be a clue to me. So increasing that vaccine uptake is critical. But the other thing is we know from the literature that African Americans, when they go during the flu season to see a provider, are less likely to get a recommendation and an offer at the same visit. Yet we know if you get a recommendation and an offer, Dr. Lynn Smith, I strongly recommend you get this vaccine. By the way, I got mine last week, and I can have my nurse give it to you today. You know what? Vaccine uptake goes up. But finally, I think within communities and public health agencies work well, or many of them work well, with community organizations. And I think it's essential that we address these concerns in this ongoing dialogue. That we begin to change what we heard in our qualitative data. People don't talk a lot about getting the flu vaccine, but if they believe people close to them, their family and friends, and their doctor want them to get it, they're trusting the vaccine, and their vaccine uptake goes up. So changing that social norm is critical. So context matters. And today, in an era when people believe that the Black Lives Movement is critical just to get respect and to feel safe in communities, then I think today it's going to take not just African American communities, healthcare providers, healthcare systems, and public health agencies all working together to change this. And here's the bottom line, or what we call the gist. We know from our work that if you take a seasonal flu vaccine every year, when there's a pandemic, as there was in 2009, you're more likely to get the vaccine. So this is work that has to be done today, not when another pandemic arrives. So I must acknowledge NIH, National Institute of Minority Health and Health Disparities, CDC, and the Food and Drug Administration for their support. Thank you.
Thank you for these wonderful papers. Do we have time for some questions? 10 minutes. Excellent. So we do have microphones, I believe. Yes, microphones. So please approach the microphone if you have a question. I know our panelists are eager to hear from the audience. Can we start with you, please?
Sure. Okay.
And then to this one.
Dr. Lynn Smith, that was a wonderful talk. Thank you so much. We heard yesterday from Dr. Howard Markel about how powerful ideologies of patriotism led to big parades in Philadelphia during the war with flu-infected soldiers, increasing spread of flu. And your narrative about African-American soldiers in the South prompts a question about what the impacts were of the dominant culture's narrative around patriotism for African Americans, where I can imagine there's a conflicted sensibility.
Quick question for you. Could questioners introduce themselves?
Sure. I'm Elizabeth French. I'm from the Gilling School.
Hey, nice to meet you. Thanks for your question. So you see people sort of mobilizing the language of patriotism in a number of ways. There are, again, the military intelligence files are fascinating and fun, because historian fun, because you hear things that you wouldn't necessarily, or you see things that you wouldn't necessarily get, because this is the other thing about World War I, is that part of the voluntarism was all about neighbors surveilling each other and reporting it back. But so in barber shops or private conversations, pool halls, you get some of this the Germans have done nothing to me, and if they have, I forgive them. This is not my fight. Publicly, in the black press, in sermons, and all of these places, you get actually a very patriotic, pro-war rhetoric from sort of self-styled African-American leaders. And in a way that actually plays almost uglily into the wartime xenophobia, right? So there'll be things, the Negro is the one American who knows no hyphen, right? Othering than other ethnic groups, German Americans or Irish Americans. But there's also this sense that this is our country more than it is almost anyone's. We built it, we did it, we have some kind of investment in the fight. And so people go in speaking that language, and part of what happens is the deep disillusioning of realizing how invested their fellow Americans are in reminding them that they are outsiders, that they don't belong. And so some people claim harder, double down on their patriotism, but other people look around in this global war and see these other people of color fighting for other countries and begin to start thinking about other forms of connection and community that might define them. Most people combine those things into kind of a self-contradictory sort of mass of emotion and response, because that's what humans do. Right?
Thank you.
Hi, my name is Matthew Peak. I'm the military collection archivist at the State Archives in North Carolina. I manage the World War I papers there for the state. So this is for Dr. Lynn Smith. One of the questions I had related to the way that information and access to care was transmitted to African American populations in the state, specifically rural. I know the collections we have from the Food Administration, the state used rural mailing lists to send information out about, they'd use it for flu or other things, but African Americans in rural communities didn't have much education, as we know from draft registration, education efforts and reading training in Greensboro. And also that African American Red Cross nurse chapters were marginalized from the white chapters. So I was wondering, during your research, what you found related to the transmission of information, how that affected care, if you came across anything like that.
So I don't know. I didn't come across anything that talked about it, but my guess would be that preachers who could read and colored women's clubs who were already doing kind of community and health-related work would be the nodes where those things were circulated. Do you know?
Yeah, I think that there's more complexity to the story than we recognize. I'm going to forget her name for a moment. Sick and Tired of Being Sick and Tired. It's really a history of the Black women's lay health movement that was really efforts by women themselves to address the health issues of their communities. But starting in 1915, there was also an effort called the National Negro Health Week, which became the National Negro Health Movement, that was begun by Booker T. Washington, and it was really it's a fascinating and yet virtually unknown part of history, in which every week there was a national theme, and the week was structured. Sunday began in the church with a preacher who had a theme, and I can't remember now how each day went, but there was a school day, there was a cleanup day to address, issues of sanitation in communities. There was I can't remember all the days now. I haven't looked at my own. I have an article on that. I haven't looked at it in years. But there was it grew to a national movement, and it really was to, within the broader Black community, it integrated not just public health people and healthcare providers, but it brought in church, it brought in the Negro insurance companies. Negro Insurance Company, I think, was one of the big funders. It was a large corporation. And so it brought together many people to address and reach people literally where they lived by people they trusted to talk to them about health and to work with them.
May I also interject, just in relation to your talk earlier, that the first time I got a flu vaccine, because I had done this ridiculous thing where I was like, I have the immune system of a horse. I spent my first 2 years of my life in the tropics. The first time that I got a flu vaccine was when my OB said, "You should get a flu vaccine. Why don't I call you one?" And I was like, "Oh, fine."
Yeah.
11 years later.
Go ahead.
Hi, I'm Sarana. So thank you, Dr. Quinn, for your research, and I was so inspired by Dr. Lynn Smith. I really appreciate you getting the voices out of the people that were experiencing the difficult times that were happening. I just blanked, but I wanted to say that this is going to be extremely challenging to get the trust of people of color, considering that the top government officials are saying things that kind of diminish the trust. And then also I heard on NPR one of the UNC public health people talking about how African Americans had a 1.5% increased rate of death during the 1918 flu, partly because there were a lot of African Americans in the sharecroppers and tenants working in the fields in North Carolina, and the housing conditions were extremely poor, crowding, etc. So I wondered if you could speak on that at all, and just thank you so much for both of your efforts.
A quick interjection. We have a minute left, so we may not get to our last question, but perhaps you could come up afterward and speak with the speakers individually.
So I think two things. Number one is, and we heard in yesterday's history session, which was fabulous, I mean, the social determinants of health are critical here. You know, when I focus on things like trust and risk perception and communication and providers, that is not to minimize the fact that we have to address those social determinants. We're not going to solve racism tomorrow. Obviously, we've come a long ways. We got a long ways to go. So we have to address what we can. But we know those determinants of health make a difference. We also know that, you know, and I have to say this because I focus on the disparities in that vaccine uptake because the disparities in chronic health conditions are so serious in African American, Native American, and many of our minority communities that they're at far greater risk, and often with less access and with social determinants that undermine their health. That said, the American population as a whole gets, if you look at whites get vaccinated about 40–45% each year. We don't do well with anyone on the flu vaccine. And while in a seasonal flu, maybe it's a mild one, maybe it's not a crisis. In a pandemic, that's potentially a huge issue. And so we have to deal with it now, but we can't lose track of the bigger context in which this all happens.
I'm afraid we have to call our panel on that note, but please join me in thanking our panelists, Dr. Len Smith and Dr. Quinn. And part of what's delightful about a conference like this is we can continue the conversations more informally after the panels, and I certainly encourage you to speak with our panelists. We have a 10-minute break. 10-minute break, get your coffee, and come back for more.